Go on.
Oh, thank you so much, Prof. Lahi. Good evening to our lovely panelists and good evening, viewers. It's always a blessing to be with you. Could you please comment and tell us where you are watching from so we know where you are? And please do well to share this video with your family and your friends and loved ones as well. Right, so I'm just going to kick off and get the ball rolling. Dr. Sam, my first question comes to you. So we know that some children are born early, they are born preterm. My question to you is that what is it that causes these children to be born early? Could you just talk us through?
Thank you. Thank you very much. And before I answer your question, I'd like to say that I feel very honored to be invited to join this panel and to answer some questions about child health. The definition of a premature birth is any birth that occurs before 37 weeks of pregnancy. We know a normal pregnancy goes to about 40 weeks. So if you're born before 37 weeks, we call it a premature birth. It occurs worldwide. It averages out to about 11 to 12% of all births are considered premature. There are some regional variations, and so you'd find higher rates in sub-Saharan Africa, and you'd find lower rates as low as 5% in northern parts of Europe. Survival rate is about 50% if you're down to about 25 weeks. And so far, the earliest known premature baby as recorded and documented in the Guinness Book of World Records was 22 weeks and 2 days. And that was a baby that was born in the state of Minnesota 2 years ago. And so far, that baby has some issues, but is doing well. To answer your question directly, there are a number of different causes, and you can classify it under, mother's health, and then issues to do with the pregnancy itself. So that if mother has some chronic conditions such as diabetes, high blood pressure, and so on and so forth, or if in relation to the pregnancy itself, there are problems with the placenta, which anchors the pregnancy into the uterus, into the womb, there can be early deliveries and problems. I don't want to go into too much detail, but those are the common causes of premature births.
Thank you so much. So we'll continue with Dr. Sam. So what are some problems that these premature babies or preterm babies face?
There are many problems associated with prematurity, especially what we define as extreme premature babies, those that are born before 28 weeks of gestation. They need very careful management because they are usually born with problems with the lung development. They may have trouble with their brain development. And in fact, sometimes the treatment or their management can also generate some complications that can affect their brain, their vision. They often have feeding problems and difficulty establishing feeding like you would in a normal baby, because they're born prematurely before all of their cues for latching on to either breastfeeding or bottle feeding. They often need assistance with feeding, and then also to do with their general development. There can be issues that come up with all of the areas of development, including their cognitive development, motor development, motor and social development. So in managing these babies, we pay attention to all of these areas in order to maximize their childhood health.
Thank you, Dr. Sam. Dr. Nyako, so as a mother of a preterm baby, what should be your concern? What should you be worried about, if anything? Dr. Nyako, can you hear me? Hello?
Hello.
Hi. Yes, so my question was addressed to you. I said, if you are a mother or a new mom to a preterm baby, what should be your concern, if any?
Okay, so if you have a baby, there are a few things that are very important. And one of the key things is keeping the baby warm. It's also, you need to also be concerned about feeding the baby, because these are some of the challenges that a preterm baby would have. And then it's important for also think about common problems that this new have, which is actually common to a lot of newborns. So they can have, depending on how long they stay in hospital, some of the things may occur in hospital, but if
I think we seem to have lost Dr. Nyako. Okay, I'm getting her back to the stream. Dr. Nyako, can you hear me, please?
yeah, I can hear you. Sorry,
That's fine. Just go.
it's
Thank you.
fluctuating again. Yes, so one of the major challenges that mothers have is feeding the baby. And most preterms may not be able to coordinate breathing and swallowing or feeding at the same time. So those are some of the challenges that the baby can have and that the mother needs to be concerned about. Can you hear me?
Yes, we can. Yeah, thank you.
Okay.
All right. So, Dr. Nyako, I think we'll continue with you. You mentioned breastfeeding. I mean, what are the benefits of breastfeeding?
Okay, so breastfeeding is also very key for a newborn, preterm or term baby. And basically, when we say breastfeeding, it means the baby is getting all feeds. It could be directly from the breast, or it could be from expressed breast milk. The benefits are to both the baby, the mother, and to the community in general. So for the baby, breast milk provides nutrients as well as antibodies, which provide immunity or protection against infection. Breast milk is more gentle to the guts than formula feeds. In addition, breast milk protects the baby against allergic conditions and eczema, and breastfed children are likely to have obesity or underweight or overweight as they grow. For the mother, breastfeeding helps her uterus to contract. It protects her against ovarian cancer and breast cancer. And it also helps her to bond with her baby. It's been found that breast milk also has some impact on the baby's cognitive function. And for the mother as well, breastfeeding prolongs the time for her, or helps her to prevent pregnancy soon after she's had a baby. And then for the community, having babies who are breastfed means that they are going to have more healthy foundation, and so we are then going to have a community of people well nourished, getting it right from the start. And then, I mean, when you look at the environment, it also prevents us from or helps us to reduce environmental waste, cans and bottles, etc., etc. So it's beneficial to everybody, and it's economical. We can life for other things. So
So it looks like we are having some network issues. Maybe Dr. Sam, if you can just round up what she was saying. Oh, okay, she's back. Okay, so Dr. Nyako, can you hear us?
sorry, Jonah, do you ask me a
Can
question?
you hear? Yes. Yeah. So so
I don't
think
know whether
we lost
maybe putting off my camera will help.
Okay.
I think it usually does help when the network is really unstable. It does help when the camera goes off. So, yeah, sorry, viewers, we are going to miss this lovely face. Let's make sure we keep the stream going. Dr. Nyako, do you want to just round off what you were saying before your network dropped again? Okay, that's fine. So I just want to say hello to our viewers who are watching. Hello, Anne, who is watching from Kenya. Hello to Pastor Martin Karimi from Kenya. Hello to Pastor James Samuel. So Chileshe, I hope I got the pronunciation right. I'm sorry, just a test of my phonics. Please tell us where you are watching from. And yeah, I know there are more people there. Please tell us where you are watching from. And you know what, this is really an important topic we are discussing. I am particularly passionate about the health of children, and the angle with which we are starting from is really essential. So please call your daughter, call your daughter-in-law, call your sister, call your cousin, call your friend, call somebody to come and join you watch this. We are also available on YouTube. So in case you don't have Facebook, you could join us on YouTube and be part of our conversation tonight. You are going to learn so much, and it's all free of charge. Guess what? So it makes it even better. Right. Okay, Dr. Nyako, I have another question for you. So you told us all about the benefit of breastfeeding. Now, my question is, should a mother be exclusively breastfeeding? Because occasionally you come across people who say, oh, I don't have enough supply. Oh, I don't want my breast to be soggy. Should they be breastfeeding exclusively, despite all the advantages you've told us? I think Dr. Gate Sam is going to step in for us. Are you happy to do that,
yes,
Dr. Sam?
yes.
Thank you.
We encourage mothers to breastfeed as best as they can, and we provide the necessary education and teaching for them to be able to do that. And we support exclusive breastfeeding through the first 6 months. If for any reason, they have difficulties, then of course the baby needs nutrition. And in a lot of places, there are excellent alternatives in the form of formulas, infant formulas that are made. And these days, there are lots of infant formulas that are made to be as close as possible. I mean, that's the best that they can say, as close as possible to breast milk, but absolutely it's not breast milk. So through the first 6 months, and after 6 months, we encourage the introduction of baby foods, which would have additional nutrients that the babies need, as well as additional calories. But in no way do we say you should stop breastfeeding. We encourage breastfeeding for as long as a mother can sustain it, given their profession and Even if they have to go outside of the home and work, we encourage that they continue to express or pump breast milk because of its benefits for as long as they can. So
my question, Dr. Nyarko, how about if a mother is not able to produce adequate milk? So what should they do?
Sorry, is the question addressed to me?
Yes.
Okay, so if the mother cannot produce enough breast milk, she needs to go back to her healthcare provider, so that we can sort of have a discussion with her.
Oh, she.
Sometimes when the mother is stressed, when she's tired, she has other children to look after, or that she's worried about something, all that can affect her breast milk production. So we would normally sort of find out if there's something that can be done to help her to produce more breast milk. If every other thing is okay and she's still not producing enough breast milk, then she would have to supplement. So it's a good idea to sort of investigate and see what is going on before we go on to the next step.
Thank you.
Right, thank you, Dr. Sam. So, growing up in Ghana, I mean, I have memories of so many infant illnesses, and it's just so horrible. and as I've become a parent now, I appreciate it even better what parents go through when you have a poorly child. Now, my question to you is, I think I have Dr. Yaki here again. Just a minute. Sorry. So my question to you is, what are some of the common childhood illnesses? And if you could just let us know if some of them are more peculiar to certain areas than others. Thank you.
Thank you, Maud. There's certainly are regional variations, but I'm sure you would all agree with me that there are some conditions that are across the board. Internationally, it's seen in children all over. By far, the commonest reason a child would say, I'm not feeling well, is a common cold. So that is the common cold, the rhinovirus that affects all of us. That by far is the commonest reason. Other reasons would be, very common reasons would be ear infections, influenza, bronchitis, RSV. Now, RSV is respiratory syncytial virus. And since we're talking about infants, that is particularly very, very important to know because it causes an acute respiratory condition in children that needs to be addressed promptly. Thankfully, because we have been giving children vaccinations, we are not seeing as many as those treacherous childhood conditions that you were referring to, Maud. We do not see as much meningitis as we used to see when I started my training. Even with pneumonias, they've gone down quite considerably. We also see things such as hand, foot, and mouth disease, conjunctivitis, gastroenteritis with dehydration, sinus infections, strep throat infections. You can see that with a lot of these conditions, they can be easily managed either by a visit to the physician or, frankly, even over the phone. A lot of these can be managed at home with advice from the physician that you consult with. Unfortunately, there are some conditions that we need to follow on a regular basis because these tend to be more chronic. And these are things such as asthma, diabetes, dehydration. I mentioned dehydration, but high fevers and difficulty breathing, those present more acute conditions that may even have to be seen in acute care settings. So these are the conditions that we pediatricians spend most of our time dealing with. Of course, the severities vary, but you would agree with me, Dr. Nyako, that these are the common conditions that we do see in our practices.
Yes, yes. I think for this side of the planet, we also see malaria after the first 6 months. That's when they get their first malaria. But otherwise, generally, they are the same.
Okay,
Thank you. Yeah, go for it, doctor.
Oh, did you have a follow-up question, Maud?
No, you go for it. No.
Okay, so as we talked about the common illnesses, Dr. Sam, you mentioned vaccinations. So what vaccines are required for children, and if you can explain the different things, and maybe Dr. Nyako can talk about things that are also germane to the developing world.
So right from birth, and in fact, I could even argue that before birth, we start thinking about preventing a lot of these illnesses in children. So for now, for instance, we encourage most pregnant women to be vaccinated against whooping cough, as well as influenza while they're pregnant. Because we're thinking about the first 2 months of the baby's life before the baby starts to get their own vaccinations. And then right at birth, in the newborn nursery, we offer vaccinations for hepatitis B. We begin that series. And then following that, we've loaded the full schedule as it pertains to this side of the world. I'm sure there may be slight variations in other parts of the world, but we look at prevention of illnesses such as rotavirus, which causes diarrheal diseases, diphtheria, which causes upper respiratory infection, tetanus, which causes a generalized infection. Thankfully, we don't see that as much anymore. Pertussis or whooping cough, Haemophilus type B. This used to be a very common illness that caused meningitis and pneumonias in children and caused them to be very, very sick. I'm glad to say I don't see that as much anymore. Pneumococcal disease, which causes a lot of pneumonias and meningitis, same as Haemophilus type B. Thankfully, we do not see as much poliomyelitis anymore. In fact, polio has been eradicated from the Western world, and there are only 3 or 4 countries in the world now that still have poliomyelitis. Influenza, that is an endemic condition that we deal with every year. Measles, mumps, and rubella, those have been reduced remarkably by vaccinations. Chickenpox is still out there. Thankfully, we don't see it as much as we used to. And now we're getting into vaccinating children against hepatitis A and human papilloma virus, as well as thinking about adolescents before they go off to universities and colleges, think about vaccinating them against meningitis. So this is a quick run through of some of the common vaccines that we offer in children. Not just children, but children and adolescents. So right through to the age of 18.
Okay, Dr. Nyako, could you?
Okay. Yes. So like Dr. Sam said, we have slight variations. On this side of the planet, we give BCG at birth because TB is endemic in our environment. So children may be exposed, and so BCG protects them against severe forms of tuberculosis. And then even though polio is eradicated, we still give oral polio vaccine at birth as well. So those two vaccines are given at birth. If the mother is Hep B exposed, then the baby will have Hep B at birth. Otherwise, it continues from 6 weeks, where they get very similar to what he said. They get a pneumococcal vaccine, they get polio again, they get the pentavalent vaccine, which includes Haemophilus, diphtheria, tetanus, and all that bash. And then we don't have mumps, so we give measles, rubella at 9 months, and then it's repeated again at 18 months. And then we give the meningococcal A vaccine also at 18 months. I think those are the main, and then we give yellow fever at 9 months. Unfortunately, our vaccination is heavily funded. And so we don't have a lot of routine vaccines that we give to adolescents. Most of them would have to be privately acquired and then given. So some people will give their children the human papilloma virus. Girls in secondary school sometimes get tetanus virus. And yeah, basically that's what we do. But in addition to the immunization, what we probably do differently is that we give some supplementation. So we give vitamin A supplementation from 6 months, and they get it every 6 months till they are 5. And then girls in school age girls, especially the adolescents, are supposed to be getting iron and folic acid tablets because there's such a high level of anemia in women. And so if they are in school, they'll get iron. It's called the GIFT program, Girls Iron and Folic Acid Tablets. So those are the supplementations that they get. Okay, yeah, that's it.
Fantastic, thank you. Dr. Nyako, so my next question comes to you. You know, there's nothing like that dreaded time of the month when you have to go to baby clinic, and then you see your colleagues with everybody comes in with their babies, and then you start looking and comparing and thinking, oh, actually, my baby is not growing adequately enough. So in that case, what should the mother be doing, and what are the causes?
Yeah, so baby not growing adequately enough always has to be looked into. Sometimes parents think their babies are not growing adequately because they are comparing, like you said, they are comparing siblings or they are comparing with their friends. So first of all, we have to assess whether really baby is not growing well. Sometimes baby is actually growing very well, and they may not be as big as their other siblings, but their growth is adequate. So if it is adequate, the mother will be reassured or the caregiver will be reassured. Otherwise, we always would go and look into nutrition. What is happening? What is the child feeding on? How often is the child receiving the feeds? Is the child getting a variety of feeds, and is it adequate? And so that's probably one of the first things we look into. Then we also want to find out if there's something else going on, and does the child have any infection that has not been picked up, or any metabolic problem or condition that has not been picked up. Sometimes children have a heart condition that has not been picked up, or in our parts of the world, one of the key things we would look at is look for HIV and TB, because those are some of the common reasons why a child will not be gaining weight adequately. We also look out for an undiagnosed urinary tract infection. So it always has to be investigated, and normally when it's purely nutritional, we put in an intervention and then we follow up the child closely to see what is happening. If we find the underlying condition, then we have to treat appropriately. I don't know if Dr. Sam has any addition.
Dr. Yako, I think you went through an exhaustive list of everything. I think that by far the commonest would be looking at the nutrition of the child, and in a lot of instances, it might mean educating the family on feeding the infant, and then excluding all of those associated conditions that you mentioned.
Great. So, Dr. Sam, we hear about developmental milestones. What are those, and when
Jonathan, whilst at it, can I just chip in one or two? I know my turn will come in, but then so I don't lose that question. So as a pediatric surgeon, there are also some causes that impede a child's growth. So Dr. Nyako and Dr. Sam mentioned quite a good number, where surgically, children with certain conditions like posterior urethral valve, which we are tending to see quite commonly in Ghana here, they have recurrent urinary tract infections, and some prescribers or healthcare providers are not conversant with that condition, and so that can also affect a child's growth. So if a child is having frequent fevers and is being picked up as having a urinary tract infection, it's one of the things to consider. Then the other thing which we also are tending to see quite common here is Hirschsprung's disease. There's a condition in which the children cannot poo, and so they have recurrent constipation, for which the mothers are often having to give them enemas. And these children look asthenic, like egg on stick appearance, and so that also has that effect. There is also certain, intestinal conditions that can affect a child's growth. So despite adequate feeding, we all know that children do throw up a bit, and sometimes also when they get to a certain age, it's going to stop. But then they are throwing up because they may have some intestinal occlusion, so like hypertrophic pyloric stenosis or some other problems. And so these are things that caregivers need to also look out for. So if a child is not meeting that milestone or the weight on the charts, I don't think they should sit at home and allow the home doctors, we call them domestic doctors. So neighbors will say, "Oh, your child is okay," or whatever it is. The child always needs to be checked. Thank you.
Okay, so Dr. Sam, if you can continue with the developmental milestones.
So thank you, Dr. Lai. From birth till about age 5, a child should achieve some skills in the way that they play, the way that they learn, the ways that they speak and act, and the ways that they move. And it's very important to track all of these for every child. It is important to follow them, because if they lack some of these skills at the time that they're supposed to get them, it may signal trouble. It does not always signal trouble, but it may. So it becomes a milestone. That's why it has that name. It becomes a milestone that for which we have to look further. So we as pediatricians, we all monitor very commonly the physical growth of every child. So at every visit, we want to look at the child's weight, the child's length or height, and then the child's head circumference. But quite apart from that, we ask questions that will shed light on the child's brain function, so cognitive development, their emotional and social development, their language development. What are they saying? You know, and with language, we look at their expressive, what they say, as well as their receptive, what they understand. Both are equally important. And then we also look at their motor development. Is this child sitting up without support? Is this child crawling? Or is this child walking? So I'll give some examples. There's so many. With every visit, we look at all of these areas, and I'll give some examples. For instance, in a 2-month-old, you expect that when you clap your hands like this, the 2-month-old should turn and look at the general direction from where that noise came. If they do not do that, you know, that is something for you to look at. It does not mean that this child is deaf or has a hearing impairment, but it could mean that. So it's just a point for you to pause and look at that. If a 4-month-old, you lay them on their back and you try to pick them up with their hands up, you expect their neck to come forward to try to come towards you. If that doesn't happen, but their neck flops back like this, that is a neurologic finding which needs further evaluation. It means that the child's tone is delayed, and that could mean a couple of neurologic conditions that need to be looked at. Another common finding, if at 6 months a child is not sitting, a baby is not sitting, you know, upright without support, that is a concern. So that is a concern in the motor development area. Another common example, which I look at every 9-month or even a 12-month visit, is to ensure that this child is starting to point in the classic way, you know, with their index finger when they need something or they see something that's of interest to them, they point to it. And that is a sign that I always look for, because it speaks to their ability to understand the environment in which they are, but not just that, to express their need. So if I don't see that, I get worried about, you know, their receptive language skills and what that could mean. Like I said earlier, and I'll stress on it again, it does not necessarily mean that, oh, this child has this diagnosis, but at least it is a reminder, or it's a pointer for us to look at the child further and maybe do some further evaluations to try to find out and pinpoint the cause of the delay in development.
Thank you, Dr. Sam. I want to say hello to Apostle Lawrence in Trinidad and Tobago. I want to say hello to Patabetha Karimi, watching from Nairobi, Kenya, and to Salmon watching from Zambia. Viewers, could you tell us where you're watching from? And once again, could you please share this with your family and friends? Thank you. So, Dr. Sam, my next question to you is there a sort of checklist for a new mother to know that at 4 months, my baby should be able to stand up and the head should tilt forward if I try to hold them? At 6 months, my child should be sitting up erect? Like, you know, all these milestones you've taken us through. Is there a checklist in every country that a new mom should know and should be looking out for? And then, assuming, oh, as you're going through the list, I suddenly realized, oh, my baby's not doing that. My child is not doing that. Then what should I do? Thank you.
Great question, Maud. Yes, there are checklists. Wherever you look, you go to Google and you type in developmental milestones, there'll be a ton of checklists that come up. In fact, there's some apps that you can download onto your phone that would ask for your baby's date of birth and whether they're a boy or a girl. And, you know, they'll ask you a series of questions. You can set it in such a way that every month or so, it reminds you to look at certain questions on that app and answer it positive or negative. And based on your responses, it will give you, you know, some things that you could do. But the best is what we all do, which are regular, what we call well child visits. So at certain intervals throughout the first year of life, we would be seeing babies at as early as 2 weeks of age, 1 month of age, 2, 4, 6 months of age, 9 months of age. Now, a crucial part of all of these visits is to go through that checklist. Either the parent fills it out themselves and then the physician or healthcare provider reviews it with them, or the healthcare provider just goes through the checklist or asks certain salient questions to check on each of these 5 areas of development. If there is a delay, then it often means that some action needs to be taken. And like I stressed before, all of these milestones are not exact. So for instance, there are some milestones, you know, when I said that when you clap, 2 months, you expect to see that, but you could see that as early as 1 month of age. So, you know, there's some ranges. If your child is not crawling by, you know, 7 months of age, it does not mean that there's a problem. It could only mean that this particular child was always put down on their back and never really got tummy time throughout, you know, their infancy to this point. So they have not developed the skill to crawl. But, you know, it does not necessarily mean a serious diagnosis, but it definitely needs to be looked at. I think it's something that at every visit needs to be discussed with the healthcare provider, be it your pediatrician or the community health nurse that sees children on a regular basis, somebody that is well versed in children's development to review some of these things. Further tests could be done. And then quite often, if it's a real delay, we get other healthcare providers involved, like speech therapists, physical therapists, and occupational therapists to help with the evaluation process, and also if they need therapy, for that therapy to be provided.
Thank you so much. So, as you've talked about, you mentioned, you know, well child visits. And so it looks like there are different times that a child needs to see a pediatrician, not because they are ill, but for wellness check. So from that standpoint, I think you've mentioned some of it at the earlier stages. So let's look at the whole kind of childhood up to, let's say, 18 years. What, I know you mentioned some of the vaccines and stuff, but what should they be doing at the different stages, especially as they are entering you know, the teenage years? Are there things that need to be, you know, kind of
Yes, in our part of the world, the well child screening, that's what I call it, actually begins at birth. So quite apart from paying attention to say things such as nutrition and jaundice, you know, at birth, every baby that is born also gets checked for a hearing impairment right at birth. They get blood taken to check for about 30 different diseases, inborn, what we call inborn errors of metabolism. And those are very important because, for instance, a baby gets checked for thyroid disease right at birth, because that is something that if you pick up, you can treat to prevent any neurologic complications from occurring. We check every baby that's born for sickle cell trait or sickle cell disease, and also an illness called fetal ketonuria, which is a rare condition for which a baby needs a special kind of diet. And the reason to check these at birth is so that if kids have these conditions, you can intervene and actually prevent complications from occurring. Every baby also gets checked for congenital heart conditions right at birth, because as you've all seen, if these are not picked up at birth, there might be some acute condition that would need an emergency kind of treatment. But if you know right at birth, then you're able to either intervene or do some sort of little procedure to prevent a complication. So at birth, and then after birth, there are visits at 2 weeks. Like I said earlier, 2 months, 4 months, 6 months, right up until 18 months. And then there are visits every year from 2 years till 18 years of age. So there are many, many, many opportunities for children to be looked at and checked. And at each of these visits, like you mentioned, we vaccinate, we check growth and development, and then there are other screenings that we do that would be specific to that age. And I'll give you some examples. For a 1-year-old, we always want to check for anemia and lead exposure. So they do get blood work for that purpose. At 5 years of age, we want to check their readiness for kindergarten. So we do what we call the SWYC. It's a particular screening that looks like the cognitive ability to work, not just academically, but socially, to be able to interact well in the school setting. And then at 11 years of age, and I've scanned a lot of years, but I want to get to some of the specific things that we do. At 11 years of age, in addition to vaccinations and a developmental check, we start screening for high cholesterol. That is something that is present in families that tend to have a problem with elevated cholesterol. And if we find that, it's one of the ways that we can prevent heart disease from even beginning at that early age. And unfortunately, at between 15 and 21 years of age, we have to turn our minds to what adolescents are doing and exploring their bodies back and forth, and we start to do screening for sexually transmitted diseases and things like that. So yes, there are age-dependent screenings that we do, but for every visit, we look at vaccines, we look at growth and development, and then of course, we would address any particular concerns that the families come in with.
So it looks like we lost Dr. Nyarko, but Dr. Tree, as a surgeon, do you also deal with kind of so-called wellness visits, or if, let's say, there are children who you've done surgery on in infancy or in early childhood, are there times where you have to see these children, and if so, kind of what are some examples and what do you do when you see them?
Right. So we generally don't do wellness clinics. We leave that to the pediatricians to do. And so when it has to do with patients we've operated on, I must say that one of the commonest surgeries we do for neonates, I'm a general pediatric surgeon, so let me talk in my aspect. That has to do with surgery with the guts. And so once we've done that and the children are feeding well and are gaining weight, we refer them back to their pediatricians to continue with their care. Some of the conditions that we follow up for quite a while may be children with undescended testes. After we fix their testes in the scrotum, we want to follow up to make sure that the testis is growing well, it hasn't atrophied or hasn't shrunken in size. And then later, when they are adolescents, you also want to examine them for changes, cancerous changes. I must say that in the part of the globe where I sit, usually once mothers are happy that what they are looking for is appropriate, that will be the end of day coming to see you. For children who are born with imperforate anus, when we do their surgeries, we want to follow them up to about the age of 5 years, to ascertain whether they have continence. And once we are happy with the extent of continence that they have, then we can dispatch them from our clinics. For the females, we may follow up for a longer period into adolescence to make sure that they are having the right gynecological checks. And then we send them over to the gynecologist, adult gynecologist, to attend to them. So generally, we don't do wellness clinics. We just make sure that surgeries we've done, yes, the target has been achieved, and then we push them over. And that is what we do.
Okay, so Dr. Nyarko, can you kind of maybe round up what Dr. Sam was saying? Is there anything different that you do in your side of the world?
Okay, so like Victor said, we don't really have wellness clinics. A few private clinics do it, but under the public service, the wellness of the children is more under public health. So they are supposed to be assessed in the child welfare clinics. Their milestones and their growth is supposed to be assessed in those clinics. And when there's a problem, then they are referred to the pediatricians. But in the private clinics, they get literally what Dr. Sam shared, and they get to have regular checks and also all the way into adolescence. Currently there are wellness clinics coming up for adults, and so the pediatricians, we also think there should be one for children. The challenge we have is that there are very few of us anyway, so accessing us will be difficult. So we have to sort of work with the family physicians and see how best we can follow up our children. But basically, all the things he said are what we do. I think that's one of the things that some parents are also concerned that we don't have newborn screening across board. Currently, we do sickle cell, we screen for sickle cell in some selected facilities. And so generally, most babies will not have newborn screening. So at 6 months, when they are supposed to have at least their HB electrophoresis and then G6PD deficiency screen done. And so at the child welfare clinics, those are requested because quite a number of children with these conditions appear when they are ill with severe anemia and when they haven't been picked up. So those are the things that we are routinely checking for. The key developmental milestones for certain ages are in our maternal and child health record books. So it's a guide for the community health nurses to be able to, and together with the parents. So it's supposed to be a book that the parents can also read and the community health nurses can also use to find out, to screen the children developmentally and know how they are doing. And once you pick up a problem and you are not very sure about it, you are supposed to refer to the pediatrician or at least to a doctor to see. I think some of the things we are currently screening when we see children and when we have the opportunity to do a well child visit is to look at also, in addition to their nutrition, look at their physical activity, because a lot of them are using a lot of, they spend a lot of time on the screen with very little physical activity. And also our psychiatric colleagues are encouraging us to also assess for mental health, especially in the adolescents. So I think those are the main things that we are supposed to do. The well child visits at the child welfare clinics, they follow the immunization schedule up to 18 months. And then after 18 months, they are supposed to have 2 visits a year till 5 years. So that occurs till 5 years. After 5 years, they are not really being monitored. The only place they might get some screening or assessment done in the public sector is in school as part of the school health program. So they get checked preschool before they go to class 1, and then they also get checked around class 3, and then when they are moving from basic school into secondary school, so around JHS 1 they get screened again, and then at SHS 2. Those are the ones that are in the Ghana Health Service system. But otherwise, in a lot of private clinics that offer pediatric service, they offer parents the opportunity to bring their children for well child visits. And then currently, the National Health Insurance doesn't cover well child or even adult routine visits. They are hoping to do it now. So if people even want it, they have to pay out of pocket. Okay, thank you.
Thank you. Thank you, Dr. Nyarko. Viewers, so far we've not had very much questions from you. Please, these doctors are here to answer your questions. You know what has been bugging you, what's been worrying you, please do send it here. You could private message me. Just put your questions out here and they are more than willing and happy to answer it. I also want to say Hajumbo to my Kenya family. I want to say hello to Ranha, Reina, Caldron, and all of you who are here. Thank you. Could you please keep telling us where you're watching from and keep sharing this? So I have a question here for you, Dr. Nyarko and Dr. Sam. So, you know, you've talked us through the vantage point that children will get screened and some of the things that may come up. But occasionally you do come across some parents who, for some reason, like you said, they've just been missing in the system, and it looks like certain things have not been picked up. And sometimes it's because they seem to have an inkling that something is not quite right. And instead of them seeking help from the doctor, they actually try to shun away from the doctors. What advice would you give to us as parents? So imagine there's someone watching who has actually tried so hard to avoid the doctor because they think these are the best of you. What would you say to them? Thank you. Dr. Nyaku, do you want to go first?
I will really encourage them that if they are worried about something, it's always best to go to the right source, because sometimes, like Victor said earlier, the home doctors may reassure you. We see that a lot. Sometimes a child has not been talking and is about to enter start school, and that is when parents first seek medical help. We also, I think not too long ago, I saw a teenager who is about to go into boarding house, and he's been bedwetting, all that while, and the parents sort of keep hoping it to get better, and they never sought for help. They only came because he's going to go into boarding house, and now they are wondering how he cope with it. So I'll just encourage you that it's always good to seek help. When you come and everything is okay, it's better to know that than to assume that things will turn out fine and then delay in seeking help. Because for some of the children, it costs them a lot. The more we delay, the more it's difficult to achieve something that can really help them, especially with their developmental milestones. It makes them so late in starting school. Sometimes children, especially in our environment, children who are on the autistic spectrum disorder, they always delay because somebody tells them, oh, your child will talk, oh, everything will turn out okay. Boys keep longing, talking, all those things that we sort of reassure parents with. And then they appear late. And then if you go to one place and you are also not very happy, you can ask them to refer you to someone else so that you get a second opinion. It's always good to tell the first health provider that, please, I think I want another, if you can let me see a specialist or someone else, because sometimes they've done some tests and all that so that they can give you everything that they've done, and you don't have to repeat some tests as well. So please come. We'll be ever willing to see you.
Thank you so much, Dr. Nyaku. Okay, Dr. Sam, my next question comes to you. So, talking about this day and age, there's something that if you haven't experienced it yet, then at least you know a friend, you know someone whose child has been poorly, who's had COVID. I'm just wondering, what is it like? Like, are children adversely affected more than adults? And what is it like between the developed and developing countries? Is it kind of like the same, or are children who are in the developed countries badly affected than children who are in developed countries? So yeah, thank you.
Thank you, Maud. As far as COVID is concerned, the experiences have been far too prolonged, and we wish this pandemic to be over. I have seen a child as young as 10 days of age testing positive for COVID, and I have seen many adolescents testing positive for COVID. My feeling is that it is primarily a disease that affects adults more adversely than children. That is not to say that children have not been admitted. We have had to admit a few children that have had COVID, but by far, adults have suffered greatly from it, much more than children. In children, their presentation is mostly mild upper respiratory symptoms, a cough, a fever, sore throat. Those have been their symptoms. And quite invariably, these symptoms are present for a variable period of time, could be 1 to about 3 to 5 days. And then they turn around and, they act as though nothing much has happened. In my practice, we have not had a child die of COVID, but we do know that in our state of Connecticut, a population of about 3.5 million, we have lost about 8 children to COVID. And by child, I mean under the age of 18. Most of these children had coexisting conditions. And so we're particularly interested in children that have immunocompromising conditions or have other respiratory asthma or cardiac conditions, because those are the children that may have an adverse reaction or a severe case of COVID. Nationwide, I know between 700 and 800 children under the age of 18 have died. So that's you're comparing this to hundreds of thousands that have died. So it has largely been a disease of adults. Having said that, in the recent Omicron surge, it has affected children more, largely because children are mostly unvaccinated. We do not have vaccines for children under 5 years of age. And so those children we have seen affected more in this surge, much, much more than they did earlier in the Delta surge. So that's been our experience. United States is probably the worst affected country. So I do believe that experience in other places is certainly different and hopefully not as severe as it has been in the United States.
Thank you very much, Dr. Sam. Dr. Etchier, so my next question comes to you. So, occasionally you would see people raising funds, GoFundMe, for a child who's been born with a cleft lip or who has like extra fingers, extra toes, and all these sorts of things. I know this is like your sort of area. So my question to you is, could you tell us a bit more? What are the causes of these things, and how should it be dealt with?
Right. Thank you very much, Maud. Yes. So congenital anomalies are quite common conditions that come in different shapes and different colors. So there are some that are quite obvious, externally can be seen, like if a child has 6 fingers and 6 toes, like Goliath, or if the child has a cleft lip or palate. And then there are those that are difficult to see, if a child has a heart disease or has a heart problem or has a kidney problem or other concealed conditions. Now there are quite a number of studies that have been done, some of which have clearly identified causative agents. So it's a whole book, a whole lecture, and I don't think I want to bore people with that. But taking drugs inappropriately during pregnancy, exposure to certain environmental factors, inadequate nutrition in the mother, so on and so forth, can lead to congenital problems or congenital anomalies. There's quite a number of them also that, despite the search, people haven't been able to identify direct causes to them, and the search still continues. Nonetheless, the child is born, there is a need to thoroughly examine the newborn baby so that once that can be readily seen, identified. Actually, I must say that identification of congenital anomalies actually starts before delivery. And so whilst the child is in the womb, various investigations can be done. And so we can have the prenatal ultrasound screening that is done. And then if certain things don't fit in, then the amniotic fluid can be taken and tested. Genetic screening for the baby can be done and all that. So there are also pointers, like if there's a family history to certain conditions that are known to be genetic, babies can be screened before they are born to pick up some of these problems. And I must say that in some places, some of these babies can have their problems treated before they are delivered, or they can have some form of intervention done to minimize the effects on the child. Intervention is done while the child is in the womb, so as to minimize the effect it will have on the baby when the baby is born. There are times also that while the baby is being delivered, some of these interventions are done just at the point of delivery so that the child can grow well. Nonetheless, when the child is born with a congenital anomaly, like I said, every newborn must be carefully examined. And then the ones that are quite obvious can be picked up. And once they are picked up, at that point at time of delivery, interventions can begin. There are some that are obscure or that are not readily identified. And so when the child is going through the newborn clinics and then the child welfare clinics, some of these problems can be identified. Or when a mother is not happy with what she is saying, she can always get attention from a care provider so as to be able to find out what problem is. So from head to toe, one can have various congenital abnormalities. And so you can have babies who have no brain, to babies who have their brains bulging out, to babies who have no toes or have no limbs. And it's a whole range, and every part of the human body can be affected with a congenital abnormality. Now, some of the abnormalities are not gross, but they are chemical. So like Dr. Sam mentioned, ketonuria and so on and so forth. So these may be, some may not really classify them as abnormalities, but then they impair the appropriate growth of the child. And so these things are also there that need to be identified, and then necessary measures taken. And so where I sit, I'm a general pediatric surgeon. So we manage the common ones that we see on our side, children who have abnormalities with their gut. So they may be born without a continuity of the esophagus, or they may be born and so they cannot eat or swallow their saliva, or they may be born and they are vomiting all the time because their intestine is blocked and must be opened up, or they may be born with their anus covered or not open, and so they can't poo, and then they have their tummies all swollen up. Then there can also be the cleft lip and palate that we also do see. On our side is the plastic surgeons and maxillofacial surgeons who handle that. And then we have the limb defects, which, depending on the severity or gravity, may fall either to a general pediatric surgeon, or may fall to an orthopedic surgeon, or may fall to a reconstructive surgeon. And so congenital abnormalities are varied. They cut across all specialties in medicine. And it's necessary that the baby is examined thoroughly, so that if there are any abnormalities, they can be identified and managed. Thank you.
So, Dr. Tree, let's continue with you. So, what are the common childhood conditions that require surgery? Like, I mean, not necessarily congenital, but,
Okay.
yeah, the common things that require surgery. And whilst you're at it, you can deal with which ones require emergency surgery.
Right. So the common, now let me say something that in the past when we used to deal with childhood mortality, emphasis was on the malaria, the diarrheal diseases, the aspect that fell on the laps of the pediatricians, and preterm delivery, congenital anomalies were not really seen that much as contributing significantly to mortalities in children. But fortunately, now there's quite some awareness about deaths from preterm deliveries, death due to congenital anomalies, and so a lot of awareness is going on, a lot of work is being done. And so if we take the child, we take them before age of one of the common things that we're seeing that we're doing a lot of surgeries on are the hernias. So we have hernias that are in the groin, that is the inguinal hernia. We have the umbilical hernia. Then there are also those that have the undescended testes, hypospadia. So let me probably just take a little time to look at. So inguinal hernia, some people don't think that children also can have inguinal hernia. And inguinal hernia is when a mother or a caregiver sees that there's a bulge in the groin of the child, and usually gets quite obvious when the child cries or strains, and then when the child is calm, it does reduce on its own. And this is because there's a defect in there, and the bowel gets in there when the child is crying, and when it calms down, it goes back in. Then there's a risk of the bowel getting caught in the ring, and that will lead to virtually death of the intestine, that segment of intestine that is caught in there. And so it can be an emergency situation. And so children, or inguinal hernia in children, I mean, must be attended to appropriately. Unfortunately, sometimes some domestic doctors or some mothers will be given the idea that, oh, it will go away when the child grows up. I mean, it is going to go away, but like has been said earlier on, if you find anything that is not right, just get close to us. We will reassure you, we will examine, we will give you the right things that need to be done, and the child will be fine. And apart from inguinal hernia, there's also undescended testes. Every male newborn must have 2 testes in the scrotum, just like an adult. And so if you examine the baby and he has only 1 or he has none, don't hope it will descend. I would say get close to a pediatrician, get close to a pediatric surgeon, get close to a urologist. They will examine and then do the right thing. We also do see conditions like hydrocele, which is a collection of fluid. I must say that the male child or the boy child has quite a number of challenges. Somehow the girl child is kind of free from a lot of these inguinal issues, and so the male child really carries a lot of challenges. So you can have fluid accumulated in the scrotum, and then that also has to be dealt with. We also do see quite commonly a condition which we call hypospadias. Hypospadias is when the urethral opening on the penis opens on the undersurface of the penis. So it doesn't open at the tip, opens on the undersurface. And this also is a problem that commonly requires surgical attention. Then children also because of their high risk of infection, do get their tonsils or their adenoids frequently inflamed, and so sometimes we need to have them removed. And so then tonsillectomy becomes quite common in childhood. We also do have children having ear infections. There's a tube in their connects the ear to their throat, which is the eustachian tube. Now, in children, it is very small, and because it doesn't offer adequate drainage to the ear, it kind of results frequently in the ear infections. And so sometimes they need to have tubes placed in their eardrum so that they can have these infections cleared. So these are conditions that present themselves as elective or cold cases. However, we do also encounter some emergencies, and apart from
so Dr. Chui, maybe before you go on, let me ask this question, which I think some mothers may be wanting to ask. So let's say a baby is born and their belly button, their umbilicus, it looks big, right? It looks big, and sometimes they are worried about it. Why is their belly button big? And some domestic doctors will say, "Oh, just leave it. It's going to get smaller as the child grows." So should the mother be worried about a belly button that is big? And is that an issue, or is there any truth to the fact that as they grow, it's going to get smaller?
Right. So that's a good question, and the answer to the question is yes and no. This is what we commonly call umbilical hernia. The umbilical hernia is quite common in blacks, and there is a familial tendency, right? So you have a father having it or a mother having it, and there's a high probability that the child will also have it. Now the thing about umbilical hernia is that usually is noticed when the umbilical cord falls off, and with the child crying and straining and stretching a lot, it tends to be increasing in size as they seem to be growing. The good thing about the umbilical hernia is that the umbilical ring can reduce in size, and in a good number of instances, by the age of 3 to 5 years, it would have closed. And I've actually seen quite some fanciful umbilical hernias that it was in a friend's child, and she kept dodging me, and eventually she said, "Oh, look, Victor, this hernia is gone, so I don't need your knife." I was fascinated by that. So there are a good number of them that can close on their own. Usually these are ones that are small ring defects, and then they tend to close. And so generally when the mother comes with a baby with umbilical hernia, we would say that, well, this is something that can close. So let's just watch and wait until they're about 2-3 years. If it's not gone and for cosmetic reasons you want it fixed, then we do fix them. However, and I say however, there are some that will never close. They are big defects. They have the umbilicus hanging on them like the horn, they're like a rhino's horn, or like the trunk of an elephant. And so by the fact that there's always intestine in that defect, in that protrusion, is not going to close. So those ones, sometimes we may close them early if the parents are so inclined. There's also the situation where the small ones, interestingly, the ones that can close on their own, sometimes can become an emergency. A loop of intestine gets into the ring, and then it fails to go back. And so we say it's strangulated. And so the umbilicals that previously could get tense and soft is now tense and painful. Tense and painful. And so when it is in that situation, we say it is obstructed, and that is an emergency, and it needs to be worked on as soon as possible. So yes and no, we can relax if there is no obstruction till they're about 3 years, and if it's not closed, we can fix it for the children. Or if they get obstructed, they get painful at any point in time, it is a cause for it being managed before the age of 3 years. Now, so actually, Jonathan, there's not just watch it to go away. Some actually will place coins on them, and then tape the coins to the umbilicus, you know, and so it becomes a domestic remedy for umbilical hernia. Now, you know, because some can close on their own, a mother may do that and the hernia closes and say, hey presto, I did that and it closed. So you can also do the same for your child, but it was going to close anyway, plus minus your coin and tape, you know. So yes, I would say that see a clinician so that he can assess it and then decide that, okay, this can close and so, or has the probability of closing, and so let's just watch. Or this has a high probability of getting obstructed, so look out for the signs of obstruction. Or this is so big it cannot close, and so let us do something about it. Yeah, so that'll be my answer for umbilical hernias. So going on to emergency surgeries. Yes, so there are diverse conditions that can present for emergency surgery in children. However, one of the commonest, and that is the commonest we see on this side, and I'm sure it is quite common also where Sam sits, and that is intussusception. Now, this is a condition that is quite common in toddlers between the ages of 3 months to 3 years, quite common between 6 to 9 months. And it's a condition in which one loop of intestine, gets invaginates into another. And so the babies are cramping, they are vomiting, and if it's not picked up early, they end up having blood in their stool, or they pass just mucus and blood. And it's an emergency, must be quickly identified and managed because the intestine is at risk of dying off, and it's quite common. Why I said there's also variations based on where you are, but there are conditions like hypertrophic pyloric stenosis where a newborn is vomiting all the time, vomits food, and it's hungry to eat the more, and these need to be attended to. When we cross the infant period and go into early childhood, I did mention the tonsils and the ear tubes. There are also these abdominal conditions which also call for quite urgent interventions, and like acute appendicitis. In the tropics, we also have enteric fever, which is also known as typhoid perforation, and they can kind of come very sick, very ill, a high morbidity and mortality associated, and they really call for hands to go on them. Having talked about hernia that are not worked on in the childhood period, in the infant period, they can also get obstructed in the childhood period, and they also would need urgent interventions. And so these are some of the things that call for surgeries. I wouldn't, the list will not be complete if I don't talk about what children like to put in their mouth and end up getting them in their airway, in their food canals, in their stomach. And that is ingestion of foreign bodies, ingestion of diverse, chemicals and fluids and what have you. And these actually can be quite troubling to these children. So they swallow foreign bodies, coins, pen tops. There's a whole host of things that they take in their toys, what have you. And so these things present as urgent conditions that they may end up having surgery of some sort. Thank you. I don't know whether Sam has any that he sends to his pediatric surgeon colleagues from his divide. As for Mamiya, I am here with her and we see them together.
Yes, talking briefly about ingestions and things that children, especially infants, put in their mouths. One very vexing problem is these button batteries
Oh,
that
yes.
that is particularly dangerous, and we see quite a bit of that over here, because those devices are used in watches and hearing aids, and uh, car key status, and things like that. So they're all over the place, and they can present a huge problem over here too, in addition to all that you said.
Usually you would see parents who would say, oh, my child just swallowed this, and instead of taking them to the hospital, they just resort to giving them something to cause them to vomit and that sort of thing. Dr. Etria, what is your opinion about doing such things, resorting to the domestic doctors, like you say?
You see, I had to sit up because that is quite concerning, and so we see that quite commonly. As soon as the child takes in something, where we sit, they are giving red palm oil, and so that makes them, because the red palm oil is irritant to the stomach, it causes them to vomit. Now, unfortunately, in fact, this evening I went to the hospital and then I met one of my nurses. Her daughter had been brought in. She had drunk kerosene, and kerosene itself is also an irritant, and had vomited and had a respiratory problem associated. So it means that the child had aspirated some of the vomiters. So the dangerous thing about giving them something to make them vomit is that they end up inhaling that agent. And so they have a kind of double effect. So apart from the agent they swallowed, which sits in the stomach, now it coming back gets into their airways, and then now you have it in the gut, and it's also in their airway. And so they end up having difficulty breathing. The agent they may have swallowed may be inert, not to have any effect on the body generally, but because it's now gone into the airway together with the acid in the stomach, it now has end up with a chemical pneumonitis. The medical people will say that. And so then they end up having sometimes being taken to the intensive care unit and being put on ventilators because of the aspiration risk that goes on with it. And so I would humbly appeal to parents that if your child should ingest anything, whether he's taking in too much paracetamol or too much kerosene, oil, whatever, you name it, just take him to the emergency department and let the clinicians do what they know to do best. Because the secondary injuries usually are the ones that take the children down. In this place, we also have children taking in caustic agents. So one practice that we see a lot is children are given water rightly from the bottle, from the water bottles, not from their cups. And so whenever they are thirsty, anything that is clear and sitting in the bottle becomes their source of quenching their thirst. And so when you have a clear agent like nail varnish remover or caustic soda, which in villages or little towns they are used to manufacture soap, they drink it. They drink bleach for domestic use and all that, and these can be really injurious to their health. And so we advise parents to be careful when they have their children with them, and make sure that they take good care of them. So the question, right, was, should they encourage the vomiting? No, don't. Take them to the emergency department and let the appropriate thing be done. Thank you.
Thank you very much. So, you know, based on what you've just said, I think that means that as parents, we should be accident-proofing our homes.
That's
so,
right.
Dr. Sam, could you just start and then just talk us through some of the things that you think every parent should be mindful of in order to avoid some of these accidents that we've just discussed? And then Dr. Etria could add to the list, Dr. Nyako could add to the list, and Dr. you could add to the list as well. Thank you.
So I will touch on two common domestic accidents that we see. And burns at home is a very vexing problem, and it's 100% totally preventable. We know that they occur in the kitchen, and they also occur in the bathrooms. And so the key to both of these is supervision. Supervision, you do not leave your child unsupervised in the kitchen ever. All it takes is a second for a burn to occur. And so it is important that you think about ways of leaving an infant, especially an infant that's crawling, that may sneak to be around your legs while you're cooking. It is important that you figure ways of keeping them enclosed in a child pack and play, or a baby swing. Or if you don't have any of those things, then there has to be somebody else that supervises the child while you cook. And it is important in homes that do have water heaters always to go to the heater and set the thermostat to the water heater to less than 120 degrees. Because if, and I'm talking Fahrenheit, I'm talking Fahrenheit. I'll have to calculate what it is in degrees Celsius, but it takes less than 2 seconds for any temperature that's above 120 seconds to cause a second-degree burn. So trying to solve this problem at the source is very, very important. Another vexing problem that causes injury in homes is drowning. And it is so heartbreaking to see a child that has drowned in their own bathtub. And there's no substitute to that. You do not leave your child in the while they're bathing for even 1 second, or even, leaving the child to go grab a towel from the closet. Before you put the baby in the bathtub, make sure you have everything that you need. And the bath time should not be any more than 3 minutes. I think if your child wants to play in the bath, then you have to commit to be with them every step of the way. The last one that I'll touch on is ingestion of medications. And in multi-generational homes, where grandma, grandpa has their own blood pressure medicine, diabetes medicines that they're taking, making sure that all of these are in lock boxes out of reach of children is very, very important, because all of these medicines look like candy. And so that's the first thing a child would do when they see it, to put it in their mouths.
Thank you. Dr. Nyako, could you please add to the list for us? Thank you.
Okay, so in addition, I'll just say that for us, caregivers may not have a water heater, but what they do is that they are going to bathe the baby and they put the hot water in a bucket, waiting to add cold water. So we rather advise that they should fetch the cold water first, and then when they are ready, they add some hot water to make it to the temperature that they want. And then, like it's been said, you never leave the baby with the water for a split second, because I mean that is when the accident will happen. Another thing that we see commonly is aspiration or nuts and corn going in the wrong way, going into the airway instead of the throat, and that causes a lot of problems because sometimes the parents don't even know that has happened. And we've had a few instances where ponytail holders, beads that they use in braiding, putting in the girl's hair, end up in a child's airway. So if you have very young children, we advise that please don't use beads for the girls, don't use it in their cornrow or their rasta. So another child will find it interesting, will remove it in class or when they are at play, and it ends up in the wrong way. And then definitely when they are young children, it means that adults should not even chew groundnuts and corn in their presence because they will cry for it. And then we'll try and sort of give it to them, and in the end, it will end up in the wrong way. So we want to encourage that. And then also, some of the accidents we see is not just from hot water, but a hot meal that they are going to serve. And so the mother has just finished cooking some porridge and she's trying to wait for it to cool and give it to the child. But the child is very hungry. So the child sort of reaches for it and then it ends up being a burn. Then we have a lot of open fires, coal pots and things in some of our homes. So they should be very careful and ensure that they sort of barricade the area or put something around these open fires so that the children don't go near it. And especially if you have a child with developmental delay, you really have to make sure that you clear their environment of anything that can go the wrong way, because for them it's even very difficult for them to tell you what may have happened. And I think Victor mentioned earlier about putting chemicals in bottles that are meant for drinking. So we tend to reuse mineral water bottles, soft drink bottles for storing kerosene, turpentine, I mean, any chemical. And these children see it and think that it's a drink. So we shouldn't use these bottles for that. And more importantly, we should also teach our children to drink from a cup rather than directly from the bottle. So that is what I'll add. Thank you.
Yeah, so if I'll take off from where Mamiya ended, also going to talk about injuries that occur when children play. And so we need to make sure that their play is always supervised. Now, they can fall from heights. Children are very adventurous. They'll climb a coffee table, they'll climb a chair. They want to be like Superman or Spider-Man. And so in testing their prowess, they end up breaking a limb here and there. And so we need to be very mindful of that. Now they may play with their friends. They may be playing with sharp objects. And in Ghana, one common thing that they do play with them, they get broomsticks and then put them in what do you call it, elastic band, and then kind of shoot them like darts, yeah. And these can find their way into the eyes of their friends or various parts. So we can have injuries that are sustained during playing. Cuts, penetrate wounds, and so on and so forth, falling off onto sharp objects and all that. So when childproofing a home, a mother must see everything that is around her as a potential object or substance for injury, and so make sure that it is out of reach, or whenever the child has to use it, it is supervised. One thing that is also a source of electrical burns or electrical injuries, sockets and electrical devices. And so we need to be mindful of that. Sockets that are not used must be covered. Unfortunately, there are covers that can be purchased and used to plug sockets, because the children are going to stick stuff in them. They see you plug in a device, and so they're also going to plug in whatever comes into their hands. So they have a spoon, they plug it in. They have a nail, they plug it in, whatever it is. Sometimes even in trying to plug in, they may have their hands on the pins of the plug, and that becomes catastrophic, So anything around the home, I mean, sometimes it may have to be to the extent that you just have to remove every furniture, every table, and make your room very, very bare, But then, I mean, depending on how adventurous your child is, you may have to do that so as to avoid these falls, because they can really be inconveniencing. You're about to go somewhere and then an accident happens and your whole life is then turned around. Not only in terms of the illness, sometimes can lead to death. So we need to be very mindful of these. So they can have fractures, they can have fall from accidents, and they can have penetrative injuries as well. Thank you.
Thank you very much. So my last question, and I think we draw the curtains on that. So whoever feels most comfortable may answer this question. So, sometimes you may have, this is something no parent wishes for, but unfortunately, you may have a young child who has been sexually abused. As a parent, how would you know, especially for the children who have developmental milestones who may not be able to communicate? Are there certain things that you should be looking out for as a parent that would let you know that maybe I need to double check my child or take my child to the hospital because I'm not quite sure on it? So yeah, anyone may answer this question. Thank you.
The pediatrician should go first.
So I will touch on this quickly. I think every parent knows their child the best. And so if after a certain encounter or behavior or activity, there may be a change in their behavior. There may be a change in their general behavior that will make you suspect that, the child is behaving, differently. And you'll have to go back and look at what they did, question them along some lines. They may have been warned not to tell anybody. And so you have that in mind. So, to answer the question, it is either the child coming openly to talk to you about it. That may not happen, or there might be a change in behavior that may lead you to question further and investigate further. In this part of the world, if you're still not sure, there are some specialists that we call forensic specialists that can investigate further. They're, child abuse specialists that may know certain clues and signs to look for that you may then seek their help from. But it's either the child talking to you directly or you see signs. In children that are old enough to have had their periods, there may be changes there too that may tip you off. So it's a difficult problem, but it's important enough that it still needs to be addressed.
So I think I will chip in a little bit that, you know, for most children who get sexually abused, it's typically by somebody who is either a family member or somebody that they know. You know, the likelihood of it being a complete stranger is low. So I think that if let's say you've left your child with a family member or somebody who's a close friend or relative, and then you start seeing kind of changes in behavior like Dr. Sam was talking about, you know, you shouldn't necessarily just think that, oh, because this is a family member or a good friend, that, you know, you don't think about that. I mean, I think you should more likely think about that, about sexual abuse, especially if this change in behavior becomes kind of more pronounced or prolonged. So a child who is very playful, very friendly, now becomes very withdrawn, and, you know, wants to stay in their room. They don't want to come out. They don't want to play anymore. You know, those should be things that make you think, has something happened? You know, and then you start by looking back and seeing, okay, where did I leave this child? You know, when did this start? And then trying to get a sense of it. But definitely, I think maybe Dr. Tree and Dr. Nyako can talk about Ghana, how this happens. But over here, there are resources. There are several resources that we have that can, you know, lead to kind of elucidating what has happened to the child.
It is definitely one of those conditions in medicine where once you have a suspicion, you have to chase that suspicion to the end. You know, there's very few medical conditions where that applies, but you have to have a high index of suspicion. In other words, the minute it crosses your mind, you have to work it to the ground to exclude it, because it is so damaging to, you know, emotionally and socially. It is so damaging to the lives of children.
Yeah, so agreeing to all that has been said, I want to add my voice to it that um, don't don't be in the habit of looking for an abnormality to say that something has happened. All right, and so I know sometimes this is where, especially when the issues get to court, it becomes like, where is the evidence? And so once you take the female child, once the hymen is intact and a swab did not show any presence of semen, then it's like, nah, you cannot prove that this child has been abused or molested. But we should know that abuse is not only where damages will take place, but the fact that an adult is touching a child in places that are not supposed to be, or do not leave telltale signs, but then that is an abuse. You know, you don't have to see cuts in the anal canal to say that the child has been assaulted or whatever. So, or have to see cane marks on the child and so on and so forth. So, like has been said, when there is a suspicion, it should be probed. Now, we have a situation in some countries where once the mother gets to know, she wants to hush it, you know, and wants to deal with it in the house because the person, the offender, is a relative. But then it is very damaging because that person doesn't stop. And because it's not going to be reported, or he knows that it's going to be taken lightly, he continues, or he or she, sorry, continues to do, and the effects can be very damaging to the child. It may not be immediate, can be in the child's adulthood, and can prevent the child from attaining his or her full potential. And so situations where it's like, okay, let's talk about it in the house, let's not take it outside, can have dire consequences. where the law must take its full course, it has to, so that it can be a deterrent, not only to the offender, but to others who have like intentions. In Ghana, we like, give it to God to be well. I mean, all manner of things, but then these end up affecting the children, and we need to move away from that way of handling it. So let us look for the offender. Let us investigate with all that we can. If it requires installing monitors or cameras, hidden cameras, so you can, find or have direct evidence, do so, because of the effect it can have on your child and his or her growth. Thank you.
Okay, so in addition to what they've said, I think that our parents have to be empowered to prevent it in the first place as much as possible. So I don't know how it is like in the US, but in Ghana, we are very trusting. People just leave their children with anybody and don't really care and don't think about it. And we need to also remember that for children, as they get into teenage years, their hormones are all over the place. So it is not really a very good idea to leave your girl or say preschooler or even early school age child with an older teenage boy to look after. I mean, the temptation is quite great to sort of teach our caregivers to look out to sort of prevent even the things from happening. We also need to teach our children about the fact that they shouldn't allow people to touch them or to show them things that are not appropriate. And they are our friends, then
looks like we lost you.
then it's easy for them to tell us when something is wrong. I think the biggest challenge is the children with developmental needs. And I think Dr. Sam has sort of explained what really happens. The parents need to know their children and to sense that something is wrong. And then they should then bring them to be evaluated if they have any concerns. Because the children with developmental needs are also at the greatest risk. When people know that they can't say it, they can't voice their objection, then they also abuse them. So we should be careful. We should advise parents so that they don't predispose them to any abuse, sexual or otherwise. Thank you.
Thank you very much for that, Dr. Nyarko and Dr. Sam and Dr. Etri. Prof. Layi, is there anything you would like to say before we draw the curtains to tonight's program?
No, I just want to say a big thank you to Dr. Sam, Dr. Etri, and Dr. Nyarko for spending these 2 hours with us. I believe this has been very informative, and everyone who has listened or everyone who's going to listen, to this is going to learn a lot from it. And I think, we are all going to become better parents to our children because of this webinar. So thank you all for sharing your expertise with us.
Absolutely. We can't thank you enough. And to you as well, Prof. Layi. So thank you all for making a date with us this Sunday afternoon, Sunday evening. There are 1,001 things that you could be doing, but yes, thank you for joining us. And viewers, if you've been affected anyway by any of these topics or the discussions that came up, then please make sure you do see a doctor, make sure you speak to someone you could trust, and yeah, by all means, do speak out and seek for help. So yeah, thank you so much once again, doctors, for making a date with us. God bless you, and we'll see you all viewers next week. Shalom.
Shalom. Thank you very much for the opportunity.
Oh, we can't thank you enough. So yeah, let's just end it on my thank you. So thank you.
At the Colony,